Hello and welcome. My name is Axel Glasmacher. I'm on the board of the CDDF and its treasurer, and it's my pleasure to welcome you to today's webinar on challenges and opportunities in the new area of immunotherapy and radiotherapy combinations. Professor Charles Simone will be our presenter today, and you will hear more about him in just a minute. Next slide, please. First, I would like to give you, at least those of you who haven't attended our meetings before, a short overview of what the CDDF is. It's a non-profit organization registered in Belgium, and we provide a neutral platform that stimulates the interaction between all the different stakeholders involved in cancer drug development. We bring together the leading voices from academia, like today, pharmaceutical industries, regulatory authorities, policymakers, and very important patient advocacy groups to improve cancer treatment. Please visit our website, www.cddf.org. There you will also find in a couple of days the recording of this meeting. Next slide, please. We have one rule here to allow a free and open discussion. This is the Chatham House rule. That means all participants are free to use the information received, but should not reveal the identity or the affiliation of the speaker or any other participant. That's, of course, a little less so for the published slides and presentation, but it certainly is for the discussion. And it includes social media. Next slide, please. The technical aspects, if you have any technical problems with accessing the screen or asking questions, please use the chat function. The chat function should not be used ideally for asking questions. For this, you will find another icon on your Zoom tool line that is a Q&A function, and any questions can be answered at any time or can be asked at any time. So please type the questions as soon as you have them. We will present the questions to our speaker during the discussion. And please, the next slide then. Program today, my co-chair, whom we'll see in a moment, is Sophia Pfister from Varian. The speaker is Professor Charles Simone. And here we go. Sophia, please briefly introduce yourself and introduce our speaker. Thank you.
Thank you so much, Axel. Hi, everyone. My name is Sophia Pfister. I'm the Director of Research Science at Varian, Siemens Healthineers company. So I directed research in-house at Varian to look at novel drug radiation combination therapies, next generation radiotherapy, as well as AI-enabled precision medicine. So it is my great pleasure today to introduce Professor Charles Simone. So Charles, actually, I know Charles through various conferences, and I was always inspired by his talk in this area of immunotherapy and radiotherapy combination. He's the research professor and the chief medical officer of New York Proton Center and full member in radiation oncology at Memorial Sloan Kettering. He's an NIH, National Science Foundation, and Department of Defense funded investigator who has published over 400 scientific articles and given over 300 scientific lectures to national and international audiences. He's the national principal investigator or co-chair of 8 NIH-funded oncology cooperative group trials and a 3-time award winner of the Association of Residents in Radiation Oncology Educator. He's also a member of the American Society of Radiation Oncology, ASTRO, Lungs Resource Panel Committee. So we're very excited to hear from Dr. Simone on this topic today. So off to you, Dr. Simone.
Hi, thank you for inviting me to speak today. I'm going to be talking about the challenges and the opportunities of combining radiation therapy with immunotherapy. I've been asked to focus on the different types of radiation therapy and how they can combine with immunotherapy with a specific focus on immune checkpoint inhibitors. My disclosures are NIH funding and Varian medical systems. So first, what are the types of radiation? Well, there's internal radiation or brachytherapy that's placing radioactive material directly into or very close to a tumor. But most of the data that we have combining radiation with immunotherapy is external radiation, which is by far the most common type of radiation delivered to cancer patients. Between external radiation, there are a few different types. The large majority is delivered as photon or X-ray radiation. There's also electrons for superficial targets, and then increasingly being used particle therapy or proton therapy. All of these work by forming double-stranded DNA breaks of tumor with ionizations. Not all photon therapy is alike, though. So within photons, historically, we had used 2D radiation, essentially blasting radiation from front to back. About 30 plus years ago, we started delivering more 3D conformal radiation. And that's essentially delivering multiple beams all affixed to a central target. And now, more recently, still intensity modulated radiation therapy, where we're able to modulate the intensity of the radiation across any individual beam that's being delivered to a target. And then within all those, we optimize radiation with image guidance, which is either X-rays to align to bony anatomy or fiducials, or CT scans, low-dose CT scans to align directly to soft tissue or tumor. Just visually, this is a 3D plan on the left, and you can see the radiation still going through and through a patient, but now more beams all converging on a single target volume here in the pelvis. With intensity modulated radiation therapy, or VMAT, you still have the convergence on a central target, but now you have radiation more spread out throughout the body. So maybe more incidental radiation, but less high-dose radiation to any normal tissue. We also have stereotactic body radiation therapy. This is important in combination with immunotherapy. This is also called stereotactic ablative radiation, or Sbrt. This implies in targeting, planning, and directing therapy in known 3D trajectory of a target. It requires very precise setup and localization of the tumor, and it's generally delivered in very, very high doses of 1 to up to 5 fractions of radiation therapy as the entire course, as opposed to historically delivering radiation over 4, 5, 6+ weeks of treatment. Typically, this is done for a single target less than about 7 centimeters. And this looks like this. It can either be done by multiple beams, so more beams than we would typically use with regular radiation. Again, all the beams converging on a target, or an arc-based approach where you're treating continuously around a discrete target volume. And you can get very, very conformal plans to very, very high doses of radiation. And then lastly, proton therapy is a little different than photon radiation in that with photon radiation, you can see the radiation goes in, hits the target volume, but then keeps going. So the radiation goes through and through a patient. With protons here on the left, the radiation goes in, it hits the target volume, and then with a known phenomenon as the Bragg peak, the physical properties of proton therapy, all the radiation is able to be deposited at that Bragg peak, and now you have no radiation beyond the target. So it allows less irradiation to be delivered to the normal tissues surrounding the tumor volume. And what that looks like, this is an example of a patient we need to treat the entire brain and craniospinal axis to. With volumetric imaging or volumetric treatment or IMRT, the radiation, again, you're treating the CSF fluid, but the radiation goes through and through a patient. So all the visceral organs like the lungs, the heart, the GI organs, all are radiated. With proton therapy, you send the radiation in, you hit the target, and then all the radiation stops. So now this patient won't be at risk of the cardiac complications, of the pulmonary fibrosis, of the nausea, and the reproductive difficulties. So how do we think about all of our different types of radiation with immunotherapy? And even within immunotherapy, there are a lot of different types of those. We certainly have vaccine therapies. These are similar to infection vaccines, which are quite popular right now with COVID. Here, we're retraining the immune cells to recognize tumor-associated antigens. There's a lot of interest in CAR T cell or chimeric antigen receptor, NK, and T cell therapy. These are genetically modified T cells that are manipulated outside of the body. Engineered receptors are then designed to recognize cancer and infuse back in the body. Certainly, there are a class of drugs that are just strong immune stimulants that have generalized activation of the immune system, but generally in not specific manner. And then we'll focus today on an inhibitory checkpoint blockade, specifically immune checkpoint inhibitors like PD-1 and PD-L1 agents, as well as CTLA-4 agents. So Where is the interest in immune checkpoint inhibitors come from? Well, they've been used much longer in a melanoma environment, and really all immunotherapies have roots in a melanoma and renal cell carcinoma. But one of the biggest trials, or early trials, that showed a benefit to immune checkpoint inhibitors in a non-melanoma, non-renal environment was in non-small cell lung cancer. These were a pair of trials, both published in New England Journal. This was Checkmate 017 in squamous cell carcinoma of the lung, and Checkmate 057 in primarily adenocarcinoma patients, non-small cell lung cancer. And here you can see these are patients that progressed on first-line systemic therapy with cytotoxic chemo and now receive checkpoint inhibitor versus next-line chemo. And here you can see a dramatic difference in survival across both histologies. This really started a phenomenon of establishing immune checkpoint inhibitors in really everything we do in non-small cell lung cancer, but then permeated to other disease sites for sure as well. Once it was well established, and using lung cancer as an example, because we have as much data in lung cancer as really anything at this point for immune checkpoint inhibitors. Once we established the use of immune checkpoint inhibitors for stage 4 patients, there's a lot of interest in looking at the potential benefit of these drugs in non-metastatic patients. And the first use was in locally advanced non-small cell lung cancer, typically the stage 3 patients. This was the Pacific trial. It was a large trial of over 700 patients randomized to, after finishing chemoradiation, either placebo or maintenance durvalumab for up to 12 months. And this has now been reported out to even as long as 5 years with a survival benefit continuing. But early reports, again, a pair of New England Journal publications showing a significant improvement in overall survival, more than tripling of progression-free survival, and a delay in time to metastatic disease or death. It also led to fewer new lesions, fewer brain lesions, higher response rates, and longer duration of response. And it didn't appreciably impact toxicity relative to the placebo. So this established immunotherapy maintenance with durvalumab as standard of care in locally advanced non-small cell lung cancer. You can see, again, survival benefit was pretty significant. The curve separated early and quite dramatically. And if you look at subsets analysis, really every group of patients benefited from immune checkpoint inhibition. And nice to see also that it wasn't at the expense of toxicity, as I mentioned, but it also wasn't at the expense of patient-reported outcomes. And in fact, essentially across all domains assessed, the patient-reported outcomes favored patients receiving durvalumab versus placebo. There certainly is a lot of interest in combining immunotherapy with locally advanced non-small cell lung cancer, essentially looking at the timing. Should we keep immunotherapy in the maintenance setting, or should it be moved up to concurrent with chemoradiation as a current question in a cooperative group trial? So why do we think we're seeing such good benefit combining radiation with immunotherapy? And can we do even better with Sbrt, that high dose radiation that I mentioned earlier? Well, we know that Sbrt is less immunosuppressive than conventionally fractionated radiation, and it actually can be immunostimulatory and deplete immune suppressive cells. So it may be a nice benefit to combining any radiation, but especially Sbrt with immunotherapy. In general, combining radiation with immunotherapy the radiation can improve antigen presentation by antigen presenting cells. Sbrt is particularly good at this since it releases high levels of tumor antigens. Sbrt also can upregulate immunogenic cell surface markers like MHC1 and can induce immunogenic cell death. And then all radiation, including Sbrt, but especially Sbrt, can increase homing of immune cells to tumor, can shift tumor-associated macrophages polarization from M1 to M2, can increase secretion of danger signals and cytokines such as TNF-alpha, and can upregulate cell surface expression of PD-L1. So even turning cold tumors that did not express PD-L1 before radiation to hot tumors that do express PD-L1. This is a nice picture that was published in Journal of Thoracic Oncology several years ago, but really showing just one aspect of what I talked about. On the left, you can see a pre-radiation model, M2 predominated. Following that, the post-radiation, you can see there's a change shifting tumor-associated macrophage polarization to M1. There's also an increased secretion of cytokines, downregulation of immune suppressive cells, a maturation of dendrocytic cells, and homing of cytotoxic T lymphocytes. So what is the data for combining Sbrt to immunotherapy, and what is the effect of Sbrt on the immune system in general? Well, in the last 4 years, there's really a proliferation of data combining Sbrt with immunotherapy. While conventional radiation is thought of as immunosuppressive due to its effect on the marrow and circulating blood, when we deliver very, very high dose radiation, and especially in a few number of fractions, like 1, 2, sometimes up to 5 fractions, we see that being immunostimulatory. This was a nice study of 40 patients looking at the effects of Sbrt on peripheral blood immunophenotype, as well as looking at cytokine and chemokine profiles. And you can see that Sbrt did a really nice job of decreasing NK cells, decreasing cytotoxic NK cells in circulating blood, and actually also increasing memory CD4 T cells. When we look at the literature combining radiation with immunotherapy, it does seem that there is more synergy and more benefit when delivering high-dose radiation, such as with Sbrt, compared with conventional fractionation. Several studies have looked at, for instance, 3 gray times 10, or 4 gray, or 6 gray times 5, and compared that to a single fraction or 3 fraction regimens. And in general, there is either no benefit, or some studies show a benefit to that higher dose per fraction in fewer number of fractions. Of course, there are some studies showing the contrary, and this is an active area of investigation. What are some lessons we've taken from stage 4 lung cancer that can be applied to earlier stage lung cancer and really all other solid tumors? Well, this was from the Keynote trial looking at pembrolizumab for stage 4 non-small cell lung cancer. This was a trial of about 100 patients. Nearly half of them had radiation incidentally before starting immune checkpoint inhibition. And the patients that had radiation before, depicted in red, versus the no radiation patients in blue, there's a significant benefit in overall survival and progression-free survival in patients that had the combination of radiation and immunotherapy compared with immunotherapy alone. This was a similar study, the Pembro RT trial, 76 patients, again, advanced non-small cell lung cancer, randomized to pembrolizumab alone or after Sbrt. So this was actually randomized, and you can see the overall response rate was literally double with the combination of radiation and immunotherapy compared with immunotherapy alone. That led to a significant progression-free survival benefit of 6.5 months versus less than 2 months, leading to improvements in progression-free and overall survival without increasing toxicity. With that, we can say there's a synergy between radiation and immunotherapy, but what about the Abscopal effect? This is something many of you may have heard of. This is a very hot topic in our field of radiation oncology and oncology in general. This stems from, quite a while ago, again, from the renal cell and melanoma experiences, but increased renewed interest with immune checkpoint inhibition. This is a patient we treated when I was at University of Pennsylvania with an anti-CTLA-4 antibody. The patient was actively progressing on ipilimumab. This was a melanoma patient. They had 3 sites of disease here. This was a very symptomatic lesion in the hip, but they also had a liver lesion and an abdominal mass. All these lesions were progressing on anti-CTLA-4 agents. We treated just this one site here, and the patient had a nice response as expected to the stereotactic radiation that generally has local control rates of 90+%. But in doing so, they actually had responses at the other 2 sites as well. So this was thought to be an abscopal effect where radiation essentially induced the immune response to allow for the immune checkpoint inhibitor to work better than it was otherwise, and treated lesions that were outside of the area receiving radiation therapy. So between trying to induce abscopal effects and between the synergy between affecting radiation and immunotherapy, really immunotherapy and immune checkpoint inhibitors have permeated all that we do in lung cancer today. This, of course, is a stage 4 trial, Energy Oncology LU002. This is a phase 2/3 trial of oligometastatic patients with 3 or fewer discrete sites of disease. And patients are randomized to maintenance therapy or Sbrt, potentially with surgery also, but Sbrt to all sites of disease followed by maintenance therapy. This trial is essentially, at this point, all the maintenance therapy is being delivered with immunotherapy, a large majority. So we're seeing more answers about potential synergy between Sbrt and immunotherapy with this trial that's well underway. In the locally advanced population, Pacific has established the standard of care as combining immunotherapy after chemoradiation, and that's really all that we do today. This is a trial of RTOG 1308, Energy Oncology trial, and again, a maintenance immunotherapy is standard of care in this trial comparing protons versus photons. This is the new Energy Cooperative Group trial that'll be opening in November, LU008. This is actually integrating Sbrt that we've been talking about at length in locally advanced patients. Historically, this has either been used for metastatic patients or early stage non-small cell lung cancer, but it's considering replacing conventional chemoradiation with Sbrt to the primary tumor, followed by chemoradiation to the mediastinum. And again, all patients are receiving maintenance immunotherapy. So what is the role of immunotherapy in early stage disease? Well, specifically looking at non-small cell lung cancer again as a case study, we know that surgical lobectomy is standard of care for these patients if they're fit and able to undergo surgery. Maintenance chemotherapy is given after surgery for patients with high-risk features or larger tumor sizes. And now we're seeing adjuvant immunotherapy or even neoadjuvant immunotherapy of use. Big publication recently on neoadjuvant immunotherapy before surgery. We're awaiting the results of ANVIL and other trials in the adjuvant setting for immunotherapy after surgery. But in patients that are medically inoperable or refuse surgery, Sbrt is a standard of care, and it does have good outcomes. Local control is in excess of 90%, but we still see, just like surgery, regional and distant failure rates are in the 15 to 25% range. We generally do not deliver adjuvant chemotherapy like we historically have adjuvant chemotherapy for surgery because these patients typically are frailer, older, more medical comorbidities and wouldn't tolerate chemotherapy as well. So immunotherapy may be particularly important in this patient population to, one, reduce the risk of nodal and distant failures, but two, also allow for some synergy at the primary tumor as well. This is the current landscape. There's several ongoing trials looking at Sbrt with immunotherapy for early stage non-small cell lung cancer. I'll quickly highlight two of them. Big trials. This is an NRG RTOG Foundation trial, Pacific 4, looking at early stage non-small cell lung cancer. Patients are treated with standard of care Sbrt and then are randomized to durvalumab versus placebo. Durvalumab is delivered up to 24 months after Sbrt. But is that the right question to ask? And again, it goes back to what is the best timing of delivering Sbrt with immunotherapy? Well, this is a study that was published in PLOS ONE looking at tumor-bearing mice treated to 20 gray of radiation, either with anti-CTLA-4 or OX40 agonist antibodies. Interestingly, depending on what checkpoint inhibitor was used or what immunotherapy was used, the answer to timing is actually different. So in this experiment, anti-CTLA-4 was most effective when it was given prior to radiation, but OX40 agonist was most effective when delivered following radiation. My current institution, Memorial Sloan Kettering, the team here looked at the melanoma population. This is a retrospective study of melanoma patients treated with ipilimumab and non-brain directed radiation. And interestingly, the median overall survival was only 9 months when radiation was given as immunotherapy was already active and being delivered. But if radiation was given before immunotherapy, then we saw a significant improvement, 39-month median overall survival versus 9-month median overall survival. So again, radiation given as maintenance, significant improvement. So question, should, for some immune checkpoint inhibitors, we prime the immune system with the immune checkpoint inhibitor first for a few cycles and then deliver radiation afterwards, as was shown in this study, to have a better survival? This was replicated in the non-small cell population in a preclinical experiment out of UC Davis, and this looked at essentially the timing of radiation. This was a control in black. Patients were delivered radiation and immune checkpoint inhibitor with a PD-L1 agent, and the timing of that agent varied. And you can see that the best cell kill was when the immune checkpoint inhibitor was delivered first, followed by radiation therapy. So that's the rationale for this trial. This is a SWOG NRG Oncology Intergroup S1914 trial that I'm the national PI of, along with Megan Daly. This is a phase 3 trial looking at inducing the immune system with priming of immune checkpoint inhibitor with atezolizumab, followed by Sbrt after 2 cycles of immunotherapy versus just Sbrt alone. So this is trying to optimize the timing as well as the synergy. This is testing the hypothesis that adding immunotherapy to Sbrt and specifically giving the immunotherapy first will improve overall survival. This is looking at patients with early stage non-small cell lung cancer, generally enriched for a little bit higher risk features. So tumors at least 2 centimeters or an SUV max of at least 6.2 on PET scan. And here you can see Sbrt is really standard of care, and the atezolizumab is just 6 months, 8 cycles every 3 weeks. So finishing up, most of course, what we focus is immune checkpoint inhibitors. We could have talked about a lot of other disease sites and a lot of other immune checkpoint inhibitors in the time that we had, using lung cancer and PD-L1 and PD-L1 agents as a case study for what we've seen in other disease sites. But I do want to underscore the fact that the interest in combining radiation therapy with immunotherapy is far from limited to immune checkpoint inhibitor. We've seen increasing data now with CAR T-cell therapy. This is actually a patient that we treated that was on an ad-interferon gene therapy trial. They were actually actively progressing on the ad-interferon and were actually in the ICU due to symptomatic disease. You can see that they have pretty significant, this was a primary malignant pleural mesothelioma that was causing cardiac arrhythmias and compression of the airway, and they ended up in the ICU as a result. We gave, while the patient was progressing on this agent, we gave just palliative low-dose radiation, conventionally fractionated, not Sbrt, and the patient had a dramatic response, more so than we would ever expect for a mesothelioma, and with conventional low-dose radiation, really suggesting a synergy. And how do we optimize this in the future is certainly an area of investigation. And then lastly, in addition to trying to optimize the timing and to optimize the dose per fraction of radiation, what about the modality of radiation? I talked about proton therapy earlier and didn't focus on that too much in this talk, but just in one slide, there may be reason to think that proton therapy in combination with immunotherapy may be an optimal approach relative to photons. We generally think because protons treats less normal tissue, it has an advantage over photon therapy as far as reducing toxicity. In some cases, that toxicity reduction may improve overall survival, and proton therapy may allow for higher doses that, without increasing toxicity, that may improve overall survival for some cancers as well. But there may be two other reasons to think that proton therapy can have a survival benefit over photon therapy, and those really relate to the immune system. The first one indirectly, and that's an increased LET or radiobiologic effective dose. Since proton therapy is a heavier charged particle and deposits more energy per linear energy transfer, it may more effectively treat some tumors and you may have more cell kill. That may be really good when combining with DNA biologic agents and potentially also immune checkpoint inhibitors as well. But to focus on this side, the immune aspect, because proton therapy is treating less normal tissue, it's treating less lymphocytes, it's treating less spleen incidentally, or other marrow-producing organs like the bone. And so you have less immunosuppression. That can allow for better synergy between radiation therapy and immunotherapy. And then also, there may be some evidence that proton therapy by itself is immunostimulatory. This was one experiment done by the NIH and other collaborators, including Chandan Guha and others from Montefiore, looking at differential gene expressions comparing proton versus photon therapy in vivo. In vitro. This was essentially showed that looking across the board, cell cycle, DNA repair, other things essentially all had the same responses to proton and photon therapy, but immune stimulatory genes may be more upregulated after proton therapy than photon therapy. So this is an active area of investigation. Certainly some of the newer trials like RTOG-1308 and LU-008 in the lung cancer space, as well as others in head and neck, et cetera, will be able to answer the question of, is there more synergy with proton therapy and immunotherapy? So in conclusion, immunotherapy is well entrenched as a standard of care for patients with metastatic solid tumors across a variety of cancer sites. Again, I focused on lung cancer as a case study since it was an early adopter, but we're seeing this really in head and neck, in esophagus, and essentially every disease site at this point, certainly for the metastatic patients, breast, et cetera. But even in the non-metastatic patients now, we're seeing increased permeation of immunotherapy in combination with radiation therapy and potentially even cytotoxic chemotherapy for our patients with non-metastatic locally advanced lung cancer and locally advanced other cancers as well. More recently, there's increasing interest in trialing immunotherapy in combination with radiation therapy for early stage cancers, patients that historically we would not think of would have as much of a benefit to immunotherapy, but again, the synergy between the two modalities may allow for that benefit. Immunotherapy may improve regional control, may improve nodal failures, may reduce distant failures, but it also may allow for primary tumor increased responses with synergy with radiation therapy. Sbrt specifically, compared with conventional fractionation in lower doses, but high dose Sbrt to just a few fractions that aren't depleting lymphocytes, et cetera, maybe even more immunostimulatory and allow for greater synergy between immune checkpoint inhibitors and radiation therapy. And certainly we need additional preclinical and clinical studies to determine what is the optimal dose, what is the optimal fractionation and the timing of radiation relative to immunotherapy. Is 1 fraction, is 3 fractions, is 10 fractions best? Is doing radiation before or after immunotherapy best? And are certain immunotherapeutic agents more likely to induce synergy and also the abscopal effect in combination with radiation therapy? So certainly this is an area of active research. There's been tremendous strides over the last 4 or 5 years, and I would be excited to repeat this talk in 4 or 5 years because I think that the field will be so much more involved at that point. Thank you very much.
Thank you, Professor Simone. That was a very impressive and a nice overview of the landscape of immunotherapy and radiotherapy combinations. And lots of your points raised are very informative and also help us to think when it comes to clinical trial design, such as the sequence of the 2 agents, the choice of immunotherapy, and the choice of indications and the stage of disease. So we already have quite a few questions from the audience, and just for the information of the audience, we will have the next 25 minutes or so to discuss any of your questions with Dr. Simone or discuss within the group. So please post your questions to the Q&A box, and we will go through the questions one by one. So
you can also vote on questions. Click on the like symbol to indicate that this is of interest to you too.
Yep, absolutely. So Axel, shall I start with the first question?
Why don't you?
Okay. Okay. Right. So Dr. Simone, we have the first question from Marcelo asking, is there any benefit of how fast the dose is delivered on Sbrt treatments when combined with immunotherapy?
Yeah, great question. And the answer is we don't definitively know. I'll give you some circumstantial evidence. So historically, when we delivered high-dose radiation Sbrt, it was done with a 3D approach. We used 7, 9, 11 fields, and that was delivered over the course of about an hour. We then started doing IMRT and fix and shoot beams, and the treatment time went down to 35 or 40 minutes. And now the large majority of providers are delivering Sbrt with VMAT that can be delivered in as quick as 5 to 7 minutes. And depending on if we have a flattening free filter and other things, it could be even quicker. So it seems that the dose rate has gone up over time in conventional treatments for these high doses, and we're seeing more abscopal effects now than before. Is it that we're looking for it? Is it that we're synergizing more with checkpoint inhibitors? We don't know. No one's ever looked at a specific dose rate question for that. There are low doses, but not necessarily dose rates. There's another question lower down that maybe I'll piggyback this answer on. There's a question Amit Sawant asked about Proton Flash. For people who aren't aware of Flash, it's essentially delivering ultra high dose rates that essentially can allow the normal tissue to not perceive the radiation dose for whatever reason. And the mechanism is probably not fully fleshed out at this time, but the normal tissues don't perceive the radiation dose to the same degree as they do with conventional dose rates. Yet the tumor kill is the same or sometimes even better in preclinical data. The first clinical trial was actually just conducted through Varian at University of Cincinnati, and the results are going to be presented at ASTRO this year. But high dose rates in excess of 40 gray per second, which is on the order of about 100-fold higher than what we typically do for clinical treatment, seems to really allow for normal tissue sparing. So the question is, can that normal tissue sparing then also allow for synergy with Flash? The question here asks, do you think immune therapy could work synergistically with Flash? I don't know. This is something our group is investigating now, and others. We would love to think so. I think that the potential tissue savings of Flash is tremendous if it works out. And it also allows us to not have to, quote, worry about immunotherapy as much. As much as we're excited about combining radiation with immunotherapy, they do have additive side effect profiles, and in some cases, potentially synergistic side effect profiles. So if Flash can reduce that risk, that could be a big benefit in and of itself. Whether it's more synergistic than conventional dose rate or not, we just don't know that data yet.
Thank you very much. Great presentation, I would like to say as well. Perhaps we stay a little on the topic of dose finding and sequence in that. So I understand that radiotherapy has recently developed even more options to be delivered. And I wonder if it's correct what I've heard from you, that the tendency is to give a higher dose in less fractions to maximize the immunological effect. Is that right?
And you're asking specifically for brachytherapy or radiation in general?
Well, for the combination with IO agents.
Yeah, so I think that's right. You know, we have data on abscopal effects and synergistic responses, which are two different things, but probably are getting binned together a lot in the literature with, for instance, 3 Gray times 10 palliative radiation doses for metastatic patients. But the field seems to be moving more toward 1, 3, or 5 fraction regimens with Sbrt, whether it's a higher dose per fraction or actually just a fewer number of fractions. So, you know, the potential benefit of a fewer dose per fractions is you may not then deplete any immune cells that are being recruited after the first or the second fraction of radiation therapy. The best data we have for abscopal effect in a clinical trial was actually published by Silvia Fermenti's group at Cornell. And she showed in a prospective trial with a CTLA-4 agent with radiation for lung cancer that the abscopal effect was 18% and disease stability was 31%. So really high numbers, 18%, when we usually think of this as kind of a unicorn, 1 or 2 out of 100 people that you're trying to get it in would. And she used exclusively 3 and 5 fraction regimens. So I think that's probably the right answer.
If I may, to follow up, pick up a question from a participant here, Rich Liu, who asked about how to decide, you know, which order, which drugs to use, and are there biomarkers that you could use to look at responses in the tumor, you know, immune cells, etc., etc. Could you tell us a little bit about that?
Yeah, great question. How to decide is challenging right now. And I think it unfortunately needs to be decided empirically. We can certainly do mouse models to try to answer that. But, you know, we've seen that there can be conflicting data in you know, preclinical work. We also seem to think that there's different answers for different agents. So even among the class of immune checkpoint inhibitors, it looks like some of them, it may be better to give the agent first before radiation. Some of them, it may be better to give radiation first before the agent. You know, a nice question would be, is it better to do the radiation interdigitated and to have some priming with the immune agent and then continue the immune agent afterwards? If radiation, quote, is kind of uncloaking the tumor from the immune system, you would then want to follow it with immunotherapy, but is priming the right answer? And I think this really just needs to be determined empirically. And we're starting to get more and more data, you know, and it may actually be different for different disease sites too. It looks like for brain, at least in some data that we have, it doesn't necessarily matter the order, or it may be better to do radiation first, but in other disease sites, maybe that's not the case.
Thank you.
Yeah, Professor Simone, just to follow up on this question of sequence, 2 questions from the audience, from Greg and Vikesh, both asking. One is, Greg asked if there is any clinical studies looking at providing immunotherapy both before and after radiotherapy. And Vikesh asks specifically for the adoptive cell therapies, should it be administered before or after radiotherapy?
Yeah, great question. So the answer is we don't have any large prospective data to date. I'm very excited. I'm very fortunate to be the national PI of the SWOG NRG intergroup trial S1914 that is looking at the exact question of giving immunotherapy first and then Sbrt after 2 cycles of an immune checkpoint inhibitor, followed by continuation of 6 more cycles of an immune checkpoint inhibitor. So we will have some of that answer. There are 3 large trials, randomized trials in the early stage non-small cell space right now. That's the only trial that has immunotherapy delivered before radiation. The other 2 trials are going to answer different questions. One is just immunotherapy after, and one is immunotherapy during and after Sbrt. So we'll have 3 different trials. It's always hard to compare across trials, but 3 different kind of thought processes. And we'll be able to see, is there one that may stand out a little bit more than the others? As far as the second question with CAR-T and NK, I don't know. I am a big believer that we probably need to prime the immune system to some extent. Is radiation and Sbrt specifically with high doses that causes a lot of local inflammation enough to do that? And maybe it is the case. In my experience, the example I showed with the gene therapy, we had to give the gene therapy first, and the patient was progressing, and then we give radiation and have a dramatic response, way more than we would ever expect. So, it also goes to the fact that maybe giving an immune stimulatory agent first can be beneficial. But again, I think it's going to be different for different classes of drugs.
Thank you. There's one question on the list that gets a lot of votes and discussion. So that is Amit Savant asks, naively, it seems that multifraction Sbrt would be more toxic to immune cells, e.g. immune cell population recruited to tumor site after FX number 1 would be destroyed by FX number 2, and so on. Yet the data suggest otherwise. Do you have any insights on why this might be? That's
I think that's a great question. Several years ago, the NCI conducted essentially a working group to think through this combination when it was very early on, and this question came up then, and years later we don't have a good answer for it. I do think that fractionation in radiation has downsides regardless of immunotherapy, and in a non-immunotherapy or early stage population, we have some data that dose escalation can help to improve tumor control, but as you start to fractionate out more to try to treat the higher doses, you don't always and consistently see benefits, and sometimes you see worse outcomes, especially, for instance, for lung cancer, the example I keep using. When you deliver more fractions, the outcomes were actually worse in survival. So is that because there's tumor repopulation potentially? Probably not, because radiation is still killing more tumor than tumors repopulating over time. So I think that's related to the effects on the immune system. And as radiation continues to go from 5 fractions to a 10 fraction palliative course to a 30 or now 35 fraction definitive course, we are causing immunosuppression. We're depleting immune cells, we're irradiating heart, we're irradiating spleen, etc. So I think in general, more fractions is probably not the best answer. It's the safest answer as far as normal tissue complications. But as we get more advanced in technology with IMRT, proton therapy, we can treat the normal tissues a bit safer. So I think the field will continue. It's already for sure been, and the field will continue to move more toward hypofractionation. Why now? So that kind of answers the question of 10 or more versus fewer than 10. As far as why is 3 fractions or 5 fractions better than 1 fraction, I don't know that we know that. I think in theory, fraction 3, 4, 5 are going to be depleting the immune cells that are being recruited after the first fraction. But potentially we don't recruit enough immune cells after the first fraction is given, or we don't switch enough, different aspects to make a cold tumor hot, or we don't do something like a polarization of M2 to M1 enough after 1 fraction of radiation. So it may take 2 or 3. In Silvia Fermenti's data, there's no difference between 3 and 5. Some groups have shown a benefit to 3 over 1 though. So I think it's still more that needs to be figured out, but it does look like for whatever reason, 3 or 5 is probably the sweet spot.
Can I ask you a follow-up question here? Obviously, at times the advantage of combination therapy is that the dose can be lower for both combination components. Has this been tested so far? in this new combination?
Essentially, yes. When we try to use radiation to definitively control a tumor, we generally do very, very high doses per fraction. For instance, again, using lung as an example, we want to treat to a biological effective dose of 100 gray, so very high dose, as opposed to 60 or so gray with a conventional fractionation approach. When we're trying to treat a metastatic tumor, and it's not for a definitive, I need to control this one site, but more, let's try to control the one site, but let's try to now allow for increased response from the immunotherapy. The doses are generally much, much lower. So instead of an absolute dose of 50 gray and an effective dose of 100 gray, we're a lot of times looking at absolute doses of, say, 30 gray, which may only be a 50 or 60 gray effective dose. So much, much lower dose. Probably not enough that is a definitive answer for controlling that one tumor, but seems to be enough to allow for this priming of the immune system.
Thank you.
Great. We have another question about a triple combination. So, Professor Simone, do you have a view of use of radiotherapy, especially photon radiotherapy, immunotherapy, and radio enhancers? So that's a question from Michael.
Yeah, that's a great question. I would love to have radio enhancers across the board, immunotherapy or not. To date, I don't know that we have a great smoking gun radio enhancer that enhances the effects of radiation without itself exerting some effect on the tumor, whether it's a cytotoxic effect on the tumor or affecting the normal tissues. If someone's aware of something different, let me know. But the field has tried to look at a specific agent, a drug agent at least, of radio enhancers for quite a while. All the ones that do, say an mTOR inhibitor, a TKI agent, et cetera, those, yes, I do see a potential role, but truthfully, most of the data we have in the metastatic setting of those agents that have an anti-tumor property have not combined well with immunotherapy, either for toxicity or people that are more likely to respond to immunotherapy are less likely to respond to, say, a targeted therapy or something else across the board. Very big generalization. So if we do have a true radio enhancer, I would love to trial it with immunotherapy. I think the issue is not as much, though, the sensitization of that individual tumor, because we still are, even with lower doses of Sbrt, controlling the tumors very well. It's really more a question of how do we more optimally cause synergy with the immune system, which we may not need a radio enhancer for.
I think someone asked about hypothermia, amide-7.
Yeah,
would that be a radio enhancer?
I think that was his point, is that could be used as a radio enhancer. Certainly has been used in several disease sites. There are positive phase 2 and phase 3 randomized trials. The best data we have is probably for skin cancers and for breast recurrences for hyperthermia. Disease sites that have some, but not great data for immunotherapy. So I think we need to understand it a little bit more. It's also harder to deliver hyperthermia in some areas. So there are other ways, and Ahmed in the Maryland group is very unique in using MR-based ways to heat areas deep in the body, not necessarily relying on a water bath. So that could be a great combination to explore as well with immunotherapy.
How about hypothermia, since we're on this topic? So cryo, cooling the tumor.
Yeah, so probably independent of radiation, because there's not a lot of data looking at radiation and cryotherapy together in the same patient. Generally the local control rates are good for cryotherapy or other ablative approaches outside of radiation based on specific tumor sizes. As the tumors get a little bit bigger, the results get a little bit worse. That being said, I'm not familiar enough with the literature to know if people have combined immunotherapy with cryotherapy enough to be able to answer that as well.
Yeah, there's some preclinical studies for immunotherapy and cryo, but yeah, I agree. Cryo and radiation need more evidence.
Okay, our next question, and not the last one because we've just received another one, is from Shushmita Sen. Can you expand on the combination of radiotherapy and immunotherapy in earlier disease setting? Rational potential benefit That also brings me to one of my questions, standard of care. Is it already standard of care somewhere? So maybe you can tell us a little bit about these areas.
Yeah, great question. I think there's a lot of rationale for using immunotherapy in early stage patients, across the board. And we're seeing in the surgical population, it can be a nice benefit. The surgery, though, we think of as immunosuppressive. So the immunotherapy is what's driving that benefit in that patient population. So regardless of the radiation and combination aspect, I think early stage patients selectively can benefit from immunotherapy in patients that are likely to respond from immunotherapy or more likely to have failures. If we take a disease site like a low-risk prostate cancer or a breast stage 1 small tumor, those patients are going to have great outcomes without needing immunotherapy. And so, we aren't going to see benefits in those patient populations necessarily. But taking tumors that are earlier stage that still have higher failure rates, we can improve outcomes just with the immunotherapy. Maybe allowing radiation, getting to the question earlier, to have a little bit lower doses in that patient population, so protecting toxicity in those patients. And then, of course, what we're really here to talk about today is maybe allowing for more synergy between the two therapies as well. And the biggest rationale is, sometimes chemo is just too toxic in those patients. And so the magnitude of benefit from chemo is outweighed or even offset by the toxic effects of chemo. So even if chemo is helping some patients to reduce the risk of distant mets that could drive a survival advantage, if chemo is causing high-grade complications and even earlier demise in, say, 4 or 5 out of 100 patients, a small benefit to chemo in an early stage population that's less likely to benefit from a systemic benefit, is going to be offset. But if now we reduce that risk of a high-grade complication with immunotherapy relative to chemotherapy, we can see better outcomes.
Thank you.
Great. Axel, do we have a time for one last question?
We have 5 minutes left. I think we should go to all the questions. So
okay,
you've selected Elmas, I think.
They are actually related, I believe. Both are asking about head and neck cancer. Shall we combine them?
Yeah.
Yeah, why not? I mean, the last question from Catherine Ellis is about potential detrimental effects and safety, and the other one is probably more general. So tell us a little bit about locally advanced squamous cell head and neck cancer, and then my last question would be around safety and toxicity, that we hear a bit about that, if that's okay.
Yeah. So, I'm far from an expert in head and neck cancer, but there was a very big disappointing trial recently. So both of these questions, I think, are interrelated. We are seeing the use of immunotherapy in advanced head and neck cancers that are squam in histology, but the role of immunotherapy in non-metastatic patients really still needs to be defined. It's still being built into current trials with the hope that it was just a delivery issue with the negative trial. Was it a lead-in factor? Was it not the right, some factor? There's even a new EORTC reirradiation head and neck trial that's building in immunotherapy as a standard of care. So I think we need to understand the role of immunotherapy in non-metastatic head and neck cancer patients a little bit more. And I think that's probably true across the board. And one thing, we didn't talk about in the talk at all today, but it may not even be just the timing or just the radiation dose or just the number of fractions. And head and neck is notorious for typically deliver 35 fractions with head and neck cancer. And we talked about, that may be immunosuppressive, which may then hurt the combination with immunotherapy earlier, whereas the benefit may be most pronounced in these 3 or at most 5 fraction regimens. So that could be part of it, especially when delivering it concurrently versus sequentially, like is done in lung cancer. One thing we haven't talked about at all is even low doses to some tumors. So for instance, the MD Anderson Jim Welsh group has looked at essentially irradiating one tumor definitively and a second tumor either just partially or to a very, very low subtherapeutic dose. And that seems to prime the immune system a little bit better. So there's still a lot of pieces I think we need to work out, across every disease site, and how do we optimize the combination of the two. As far as the toxicity question, yes, it's the literature is a little bit inconclusive in that we know that immunotherapy, especially if we're sticking with the PD-1, PD-L1 discussion, the biggest concerns are these, inflammatory effects, especially say pneumonitis. If we're trying to treat a lung target, if 4 or so % of patients are getting pneumonitis from the agent, and then, it could be double digits are getting that pneumonitis from radiation, is there a risk of synergy between the two pneumonitis, even though they're different mechanism, even though the timing of each is different? That could be, even if not synergistic, even just additive toxicity can be life-threatening for patients. Some studies have suggested that there's really no added toxicity. In fact, if you look at the Pacific trial that I showed earlier, there's absolutely no difference in pulmonary toxicity. If you look at trials that move immunotherapy concurrently with radiation, though, it does look like there's a little bit of an increase. We participated Penn, Rutgers, and Yale did a locally advanced multi-center trial moving immunotherapy concurrently with radiation. It's now being tested in the cooperative group with ECOG Akron. That did look like it did increase high-grade toxicity in a small number of patients. So we need more data. Maybe the safest thing is to interdigitate immunotherapy between cycles interdigitate Sbrt between cycles of immunotherapy. But I think ultimately we're going to see that there is an increase, but it's a small increase in toxicity, and it's probably worth the benefit if it helps with the immune response, which is still a matter of discussion.
Thank you very much.
Thank you so much, Professor Simone, and thank you to the audience for the great questions. I hope we answered all your questions. If you have questions, please feel free to reach out to us or sending your feedbacks after this webinar. Just a forecast for you. Following this webinar, we also have a second webinar. So this webinar has addressed the evidence generation, the scientific rationale of immunotherapy and radiotherapy combination. But we know also when it comes to the regulatory, to the approval, there's certain areas of challenges as well. We need more clarity and we need more guidance on how to combine a device and a drug, for example. That's why we have a second seminar webinar in about a month or two to specifically look at the regulatory considerations for immunotherapy and radiotherapy combinations. So hope to see you there.
Thank you, Sophia. So we stay tuned on this exciting topic, but I would also like to use the opportunity to make you aware of two full two-day workshops from the CDDF later this year in September. It's about patient access and engagement in oncology drug development. This will be held in Amsterdam. We had our first hybrid workshop last week in Amsterdam, and I must say it went really well. There was a good crowd in the room and a large audience online, and you are very welcome to attend this workshop or the next one on histology-independent drug development. Is this the future for cancer drugs in November this year? So please stay tuned and if you can attend these workshops. Next slide, please. I of course would also like to thank, first of all, our speaker, Charles Simone. Many thanks for a fantastic presentation and discussion. My charming co-chair, Sophia, thank you for all the work you put into this. And of course, you, the audience, late in the day in Europe, at least, staying with us here. You can get a certificate of attendance if you fill out the survey form by scanning the QR code or via the link that has just been sent in the chat. So stay a little on this website and copy the link or the QR form and fill out the survey. You can understand that this is an interactive exercise and your feedback is very important. With this and many thanks and a very good rest of the day to everyone, I would like to close this webinar. Thank you very much.